Imagine you are sitting up in a meteorology tower. You are staring intently at this massive weather radar screen.
Right. Keeping watch.
Exactly. And occasionally, a really violent thunderstorm just sweeps across the display. It's this massive, undeniable electrical event. It lights up the monitor in vivid reds and deep purples, completely dominating the atmosphere.
Leaving absolute chaos in its wake.
Spot on. That is epilepsy. You can physically see the electrical origin, you can track its progression across the cerebral hemispheres, you can measure its intensity, but then occasionally you look out the window of that same tower and you see a completely different, terrifying reality.
The storm on the ground.
Yeah, the trees are thrashing violently, the sky is pitch dark, buildings are taking damage, but when you glance back at the radar screen, it is completely clear.
Not a single blip.
Not one. The storm is profoundly real to the person experiencing it. The impact is devastating. But the origin is entirely different. And that phenomenon, that storm without the electrical signature, that represents the reality of psychogenic nonepileptic seizures.
I love that framing. The contrast between those two storms really sits at the absolute core of our discussion today. Because, when we talk about psychiatry, we are fundamentally talking about the study of how the brain, the mind, and human experience interact.
And how that process can just go disastrously wrong.
Precisely. We are exploring what happens when the literal electrical foundation of the brain misfires, sending shock waves through a person's psyche. And conversely, we are looking at how profound psychological distress can essentially bypass conscious control and perfectly mimic those exact same electrical misfires.
It is such a fascinating intersection. Welcome to the Deep Dive, everyone. Today we are exploring the neuropsychiatric aspects of epilepsy and nonepileptic seizures. We are anchoring our conversation in Chapter 2.4 of Kaplan and Sadok's comprehensive textbook of psychiatry.
But to be clear, our mission today is not to just read a textbook at you.
No, absolutely not. The goal is to build a conceptual synthesis. We want to construct mental models for you, whether you are a psychiatry trainee, a clinician, or just a deeply curious student of the mind. We want to clarify how a clinician thinks when faced with a patient whose symptoms blur that boundary between a hardware crash and a software glitch.
It is a vital companion to the text. And a crucial framing for anyone joining us is that similar outward behaviors can arise from fundamentally different neurobiological processes. So we will move systematically from the mechanisms to the clinical manifestations and finally to the clinical reasoning.
Let's start with the history, because it is genuinely bizarre. It serves as a massive warning about how misattributing the cause of a disease just creates immense suffering.
Oh, the historical whiplash is incredible.
Right. If we go back to antiquity, Hippocrates wrote a text called On the Sacred Disease around 400 BC, and he was actively fighting this massive battle against superstition.
Because society viewed a seizure as demonic possession, or a punishment from angry gods.
Exactly. But Hippocrates boldly argued, no, this is a disease of the brain. He thought it was caused by an excess of phlegm blocking vessels.
I mean, he got the anatomy right. The brain is the source. The phlegm theory was a bit off, but he was on the right track.
But then humanity just ignored him for 2 millennia. During the Middle Ages, the medical model completely vanished.
Replaced entirely by theology. Exorcisms, bloodletting, trephination, drilling holes in the skull to let spirits out. And because it was viewed as a moral failing, this permanent social stigma attached itself to the patients.
A stigma they still battle today, unfortunately.
Yeah.
But then the Enlightenment happens and medicine starts looking for scientific explanations again, though they arrived at some deeply flawed conclusions.
That is putting it mildly.
Yeah. By the 18th century, prominent physicians decided that epilepsy was caused by masturbation.
The Victorian era was entirely dominated by this medicalized morality. They saw physiological arousal, changing heart rates, and theorized the nervous system was getting overloaded by sexual activity.
Which is scientifically baseless, but it accidentally led to a massive pharmacological breakthrough.
It really did, because they were trying to cure the patient's libido, right? So they gave them bromides.
Which were used to diminish sexual desire.
Exactly, and aphrodisiacs. But by sheer serendipity, bromides possess potent anticonvulsant properties. They calm central nervous system excitability, so patients stopped having seizures.
It's amazing. They treated the wrong cause with a drug for the wrong symptom, and it actually worked.
It paved the way for modern anti-epileptic drugs. And eventually, the EEG in the 20th century allowed us to finally see the electrical storms. Bringing us right back to Hippocrates, epilepsy is an organic brain disease.
Which brings us to how we categorize those storms today. the 2017 ILAE classification.
Yeah.
It shifted the focus entirely to etiology and mode of onset.
And this classification is essential for your mental model because it forces you to think anatomically. We divide seizures into two primary categories, generalized and focal.
Let's break those down. Generalized onset means what exactly?
It means an initial, widespread, bihemispheric electrical discharge. From the very first millisecond, neural networks on both the left and right sides of the brain are firing hypersynchronously.
So when most people picture a seizure, the classic bilateral tonic-clonic convulsion, the old grand mal that is a generalized onset.
Precisely. Abrupt loss of consciousness, a tonic phase of rigid muscle contraction, forcing air out, usually causing a cry. Then the clonic phase with rhythmic, violent jerking.
But not all generalized seizures look like that, do they?
No, consider the absence seizure or petit mal. It is generalized, bihemispheric from the start, but clinically it is incredibly subtle. A child might just stop talking and stare blankly for 10 seconds.
No violent thrashing at all.
None. But neurologically, it's massive. On an EEG, you see this classic generalized 3 Hz spike and wave discharge. The key is the brevity, no aura, and immediate return to full awareness with zero confusion.
Okay, so that is generalized. The other side is the focal onset seizure. This seems to be where the neuropsychiatry gets really nuanced.
It does, because the electricity isn't engulfing the whole brain at once. It emanates from a specific localized network limited to one hemisphere. You might hear older terms like partial seizures, but focal is the modern term.
And the defining variable for a clinician here is awareness.
Right. Focal seizures occur either with or without an impairment of awareness.
So if it happens without impaired awareness, the patient is awake, they can hear you, but part of their brain is misfiring.
Exactly. Previously called a simple partial seizure. They remain cognitively intact, but experience sudden symptoms depending on the location. Motor cortex misfires, their hand twitches, occipital lobe, flashing lights.
And what if it is in the temporal limbic system?
Then they might get a sudden rush of fear, a rising feeling in the stomach, or a profound sense of déjà vu.
Which means an aura is not a warning sign of a seizure.
This is a vital shift. The aura is the seizure. It is a focal seizure without impaired awareness. It's the leading edge of the storm.
Wow. Okay, but if the storm spreads...
If it spreads to regions involved in consciousness, it evolves into a focal seizure with impaired awareness. The old complex partial seizure. The patient stops, stares, and you see automatisms, lip smacking, chewing, picking at clothes. They are profoundly altered.
Understanding that spatial progression is key,
Yeah.
But we also have to map out the temporal geography.
Yeah.
Because psychiatry lives in the hours and days surrounding the convulsion, right?
Yes. The temporal framework organizes our diagnostic thinking. We have the ictus, which is the seizure itself.
The main earthquake.
Right. Then the postictal period, the immediate aftermath. Lots of confusion and EEG slowing as the brain recovers. Then the interictal period, the baseline time between seizures.
A rebuilding phase.
Yeah.
And the text mentions periictal.
Periictal just describes phenomena hovering right around the edges of the event where boundaries are blurry. The foundational takeaway for you listening is that severe psychopathology, psychosis, depression, mania can manifest in any of these temporal phases.
So to understand why that happens, let's look at the cellular mechanisms. What is physically failing to cause this earthquake?
Fundamentally, epilepsy is a disorder of excitability. Neurons become hyperexcitable. The brain relies on a delicate balance between excitation and inhibition. A seizure is a catastrophic mechanical failure of that balance.
The brakes give out and the accelerator gets pinned to the floor.
Exactly. Biochemically, the braking system is GABA, the main inhibitory neurotransmitter. During a seizure, GABA inhibition fails. Chloride channels don't open enough to calm the cell.
And the accelerator?
Glutamate. There's a massive surge of this excitatory neurotransmitter binding to NMDA receptors. Calcium and sodium flood in, driving neurons into relentless repetitive firing.
And what is so elegant here is how anti-epileptic drugs, or AEDs, map perfectly to this plumbing issue. They're targeted molecular mechanics.
They really are. Drugs like phenytoin and carbamazepine act on the accelerator. They stabilize voltage-gated sodium channels, preventing the neuron from firing too quickly. Ethosuximide blocks calcium currents, which is why it works for absence seizures.
And fixing the brakes.
Benzodiazepines bind to the GABA receptor complex. They don't replace GABA, but they enhance it, keeping the channels open longer to shut down the storm. Valproate blocks the breakdown of GABA. Every intervention is restoring that balance.
Which brings us to what might be the most counterintuitive insight in the whole chapter. If it's just a mechanical plumbing issue with sodium channels, why do 20 to 60% of epilepsy patients experience severe psychiatric problems?
Right, the instinct is to say, well, living with a chronic stigmatized illness is stressful, so they get depressed.
Which makes sense on the surface.
It does, but it's a fundamental clinical error. The relationship is not unidirectional. It is profoundly bidirectional. Yes, epilepsy patients are more prone to major depression and psychosis. But patients with a primary diagnosis of major depression or anxiety actually possess a significantly higher statistical risk of developing epilepsy later in life.
Wait, I really want to emphasize this. If I develop standard major depressive disorder in my 20s, my brain is at a higher risk of having unprovoked electrical seizures a decade later.
That is exactly what the data shows. It points to a shared underlying neuropathology. The neural networks that regulate mood and reality testing are the exact same limbic and cortical structures prone to epileptiform discharges.
So the hardware running the mood software and the electrical hardware are one and the same.
Yes. A defect in a circuit might manifest as depression in one person, a focal seizure in another, or both simultaneously.
To help clinicians navigate this, the literature proposes 6 distinct mechanisms for this overlap. Let's run through them. Mechanism 1 is structural, right?
Yes, common neuropathology or genetics. The classic example is mesial temporal sclerosis, a physical scar deep in the hippocampus.
Which is the epicenter for memory and emotional processing.
Exactly. That physical scar acts as a highly irritable focus, generating temporal lobe seizures. But it also physically disrupts the limbic circuits responsible for mood. So one lesion causes both the epilepsy and the chronic depression.
Mechanism 2 is kindling. I find this one fascinating. How does a seizure rewire the brain?
It's neuroplasticity gone wrong. Imagine kindling a fire. You apply a subthreshold flame to wood over and over, and eventually it catches. In the brain, if a limbic structure gets bombarded by subthreshold electrical discharges for years, it lowers the threshold for firing.
Even if there isn't a full clinical seizure.
Exactly.
Yeah.
The constant static electricity slowly alters synaptic connections, creating aberrant emotional pathways that manifest as mood lability or paranoia.
Mechanism 3 seems like the opposite, the absence of function.
Right. When we do PET scans on chronic epilepsy patients, we frequently see severe interictal hypometabolism. The brain is actively suppressing metabolic activity and blood flow in the area surrounding the seizure focus.
To prevent a fire.
Yes, it's a protective mechanism, but it comes at a psychiatric cost. Suppress the frontal lobes, you get severe cognitive blunting and apathy. Suppress the temporal lobes, you induce depression. The brain starves the tissue to stop the seizure, causing a psychiatric deficit.
Mechanism 4 is neurochemical.
Seizures are violent events. They trigger massive fluctuations in neuroendocrine systems. Post-seizure, you see profound alterations in dopamine receptor sensitivity, massive surges in endorphins, shifts in the HPA axis. These neurochemical tsunamis linger and alter effect in reality testing.
Mechanism 5 brings in the psychosocial reality.
Because while it's not just a reaction to stress, the psychological burden is immense. The unpredictability breeds learned helplessness. Seizures can cause injury and humiliation in public. That chronic social isolation severely disrupts reality testing and potentiates the biological vulnerability.
And the final mechanism, number 6, is one we cause. AED side effects.
Iatrogenesis. The medications we use to calm the storm have massive psychotropic footprints. Polypharmacy or high dosages can directly cause acute psychosis, severe agitation, or profound depression. Treating the seizure frequently causes the psychiatric symptom.
Okay, so we have the anatomical framework, the timeline, the 6 mechanisms. Now let's look at the clinical manifestations. Let's walk through the temporal phases, starting with the ictal features. During the seizure itself.
Right. Let's look at psychic auras. These occur in a clear sensorium, meaning the patient is awake and aware.
The textbook mentions Dostoevsky here, which is amazing.
Yes, he suffered from severe epilepsy and documented his ecstatic auras. He described a sudden, overwhelming feeling of perfect harmony with the universe, a deep connection to the divine.
He said he would exchange 10 years of his life for a few seconds of that cosmic bliss. If a patient describes that, what structures are misfiring?
It strongly implicates focal discharges in the anterior insula, the amygdala, or the temporal neocortex. The electricity is artificially stimulating the networks for meaning and well-being.
But ecstatic auras are pretty rare, aren't they?
Exceptionally rare. A much more common and distressing aura is ictal fear.
How is that different from a panic attack?
Ictal fear is an abject fright that emerges instantaneously, completely unprovoked by external stimuli or internal conflict. It's an abrupt hijacking of the amygdala. The patient feels impending doom, followed seconds later by a loss of awareness.
Patients also report derealization, where the world feels flat or artificial, or depersonalization, floating outside their body.
And those perceptual distortions are highly destabilizing. If your brain constantly subjects you to unprovoked fear and a feeling that reality is fake, it severely impairs long-term reality testing. It's a major reason temporal lobe epilepsy predisposes patients to interictal psychosis.
There is another symptom the text warns about: forced thinking. This sounds identical to intrusive thoughts in OCD. How do you tell them apart?
It requires a deep understanding of phenomenology. Forced thinking is a sudden, intense crowding of thoughts, a specific phrase flashing into the mind. But unlike OCD, epileptic forced thoughts are incredibly brief, highly stereotypical, the exact same thought every time, and totally disconnected from the environment.
And how the patient relates to it is different, right?
Right. Exactly. In OCD, the thoughts are ego-dystonic. The patient hates them and feels an urgent need to perform a compulsion to neutralize the anxiety. In forced thinking, there's no compulsion. The thought just happens to them as a brief cognitive rush, and then the aura resolves or evolves.
Moving to the fringes of the storm, the periictal phase, I want to ask about a massive forensic myth. You see this on TV all the time, the epilepsy defense. Can a seizure cause someone to commit premeditated violence?
The clinical consensus is an emphatic no. Directed, calculated violence during a seizure has almost zero basis in neurological reality. The text references a famous 1976 case of a policeman trying to use this defense, which led to strict criteria for ictal violence.
Why is it neurologically impossible?
Premeditated violence requires tracking a target, selecting a weapon, planning an escape. That needs highly coordinated prefrontal cortex function. During the chaotic discharge of a seizure, that coordination is physically impossible. You might see aimless automatisms blindly flailing or pushing, but it is devoid of calculated intent.
But patients do become violently aggressive sometimes after a seizure.
Yes, but that is almost exclusively resistive violence during postictal delirium. The patient wakes up exhausted, disoriented, and terrified. If a paramedic forcibly grabs them, the delirious brain misinterprets it as an attack. It's a primitive fight-or-flight response. If you step back, the aggression usually dissipates immediately.
That's a vital distinction. Let's look at another periictal phenomenon, postictal psychosis. Walk us through this timeline because it's a massive diagnostic trap.
The timeline is pathognomonic. It usually happens in patients with long-standing epilepsy. They experience a cluster of generalized seizures. The seizures stop, they go through standard confusion, and over a few hours, they clear up.
This is the trap. They look totally fine.
Right. They enter a lucid interval. They are conversational-oriented. Neuroexam is normal. The ER doc says they've recovered and discharges them. This lucid interval lasts 2 to 72 hours, averaging about 24 hours.
And then
Abruptly, the psychosis erupts. They develop a florid psychotic state lasting about 3.5 days. Intense paranoia, grandiosity, religious delusions, severe agitation. Fascinatingly, usually without prominent hallucinations, the delusional architecture is just highly rigid.
So if a clinician doesn't know about that lucid interval, they'll misdiagnose a primary schizophrenic break.
Which leads to inappropriate long-term psychiatric treatment. Recognizing that 24-hour delayed onset as a transient neurobiological phenomenon allows you to manage it correctly. It usually remits spontaneously or with a very short course of low-dose antipsychotics.
Which brings us to the interictal features, the long stretches between storms. What's happening psychiatrically when the EEG is quiet?
Depression is the most prevalent comorbidity, affecting up to a third of patients, and some clinicians identify a specific syndrome here, interictal dysphoric disorder.
How does that look different from standard depression?
It's a chronic, grinding, low-grade depression, but it's punctuated by paroxysmal episodes of intense irritability and explosive agitation. A patient might be sitting quietly, and suddenly they're overwhelmed by a storm of dysphoric anger from nowhere.
The electrical instability manifesting as emotional instability.
Exactly. And interestingly, it often responds robustly to standard antidepressants.
Now, there is a concept regarding treatment that is absolutely mesmerizing. Forced normalization. I want to make sure I understand this completely. How does this present?
It's a profound paradox. Imagine a patient with poorly controlled seizures. You introduce a highly effective new AED or do surgery. It works perfectly. The seizures stop. You run an EEG, and the chaotic brainwaves are completely suppressed. The EEG is forced into a normal state.
Neurologically, they are cured.
Yes. But psychiatrically, they crash. As the electricity normalizes, the patient abruptly develops severe intractable psychosis or profound depression. The only way to prove the phenomenon is to lower the dosage of the new medication.
And when you lower it, they have a breakthrough seizure.
And the very moment the seizure returns, the psychosis or depression vanishes completely. They alternate.
It's like the brain was using the seizures as a pressure release valve for the psychiatric vulnerability.
That's a brilliant way to conceptualize it. It is essentially an endogenous form of electroconvulsive therapy. We use ECT to intentionally induce a seizure to treat severe depression. Here, the brain was inadvertently self-medicating with its own seizures. Take the seizures away, the psychosis emerges unchecked.
That sounds like a nightmare to manage.
It requires immense finesse. The psychiatrist and neurologist have to compromise. Total seizure freedom might actually not be a safe goal for that specific patient. You have to find an equilibrium.
Let's pivot to personality changes. The historical epileptic personality. Where does modern science stand on traits like viscosity and hyperreligiosity?
Historically, clinicians described viscosity, this conversational stickiness where patients are overly detailed and can't read cues to end a conversation. They used the Bare Fidio inventory to measure it. But calling it a personality disorder is deeply stigmatizing.
So how do we reframe it?
Through cognitive neuroscience, we focus on impairments in theory of mind, or TOM.
Which is the capacity to understand that others have different thoughts and intentions. Cognitive empathy.
Right. The temporal lobes, especially the medial and anterior aspects, are hubs for processing social semantics and facial expressions. If those structures are constantly bathed in abnormal electricity or scarred by sclerosis, the hardware glitches. The patient physically loses the neurological ability to read subtle social cues.
So if a patient is being viscous, standing too close, talking continuously, they aren't being intentionally difficult.
No, they cannot compute the implied meaning of someone looking at their watch. Reframing this as a localized neurological deficit in social processing completely changes how you support them.
And does it matter which side of the brain the focus is on? Lateralization.
It matters profoundly. A left-sided temporal focus is robustly associated with a significantly increased risk of interictal psychosis. On the MMPI-2, these patients score much higher on schizophrenia scales. MRI studies show accelerated gray matter loss in the left hippocampus and insula in these patients. The link to psychosis is firmly tied to the left hemisphere networks.
Okay, we have mapped the electrical storms extensively. We've seen how rogue currents generate fear, trigger psychosis, and alter empathy. Now we have to transition to the second major topic. What happens when you watch a patient have a violent convulsion, unresponsive lip smacking, but the real-time EEG shows absolutely zero abnormal electricity?
That is Psychogenic Nonepileptic Seizures, or PNES, and this is where the boundary between neurology and psychiatry requires the absolute highest level of clinical skill and empathy.
Let's define it. What is PNES?
In the DSM-5, it's a subtype of functional neurological symptom disorder, FNSD. Older clinicians know it as conversion disorder. These are sudden, involuntary episodes of altered movement and awareness that outwardly mimic epileptic seizures, but occur with normal, waking brainwaves. The origin is functional and psychological.
I really want to emphasize the word involuntary, because historically, these patients were viewed with suspicion, like they were malingering.
That view is totally discredited and clinically destructive. They are not faking. They are experiencing a terrifying loss of conscious control. Modern neuropsychiatry uses the integrative cognitive hypothesis to explain this.
How does that account for a full convulsion without an electrical short circuit?
The hypothesis posits that a psychogenic seizure is the automatic reflex-like execution of a learned mental representation of a seizure. We have top-down cortical inhibitory processes that monitor behavior. In PNES patients, chronic stress, trauma, or hyperarousal causes those inhibitory networks to fail.
The software managing the system crashes.
Precisely. When inhibition goes offline, a minor trigger causes the brain to automatically execute a seizure program from its predictive modeling. It's a dissociative reflex. The body thrashes, awareness is altered, but the cortical electricity hums along normally because it's a software execution, not a cellular depolarization.
That makes so much sense.
Yeah.
But clinically, sitting in the EMU, how do you differentiate them visually before the final EEG report?
Semiology, the study of clinical signs. Table 2.413 is a masterclass here. First indicator, duration.
Because true seizures are metabolically exhausting.
Right, they usually burn out in under 2 minutes. PNES episodes frequently last much longer, often greater than 2 minutes, sometimes 20, and they wax and wane. The thrashing stops, then restarts. Epileptic seizures rarely do that.
And what about the eyes? I found this fascinating.
In a generalized epileptic convulsion, the eyes are almost always open and deviated. In PNES, the eyes are typically tightly closed. If you try to gently pry the eyelid open, they exhibit forced eye closure. They actively, unconsciously squeeze them shut.
Which proves there is active motor control being maintained, which is impossible during a true bihemispheric convulsion.
Exactly. It's a dissociative defense mechanism. We also look at movements. Epileptic clonic jerks are rigidly rhythmic and synchronous. Both arms jerk together. PNES movements are frequently highly asynchronous, thrashing out of phase, side-to-side head shaking, pelvic thrusting the arc to circle.
And the recovery phase.
PNES patients often recover rapidly, completely skipping the prolonged postictal delirium. They sit up and are instantly alert. Their breathing might be shallow, unlike the deep snoring respirations of an epileptic postictal state.
Okay, so long duration, waxing and waning, eyes closed with resistance, asynchronous thrashing, we suspect PNES. But there's a massive trap here, the frontal lobe trap. Explain why frontal lobe seizures break all these rules.
This is critical for emergency clinicians. Frontal lobe seizures are true electrical seizures, but they perfectly mimic PNES semiology. The frontal lobes have vast motor connections. A highly localized seizure there causes bizarre hyperkinetic movements. Bicycling legs, pelvic thrusting, it looks completely psychogenic.
And a standard scalp EEG might not even catch it.
That's the crux of it. The focus is buried deep in a sulcus. The surface electrodes record normal alpha waves. So you see bizarre thrashing and a negative EEG, and you incorrectly diagnose PNES.
How do you avoid the trap?
You look for specific differentiating rules. First, frontal lobe seizures are incredibly short, usually under 30 seconds, unlike PMES. Second, they almost always occur abruptly out of confirmed sleep, whereas PNES is a disorder of waking consciousness. Third, the eyes are wide open, and there's often brief tonic posturing before the thrashing.
So if it's a 15-second episode out of deep sleep with open eyes, suspect frontal lobe origin, regardless of the surface EEG.
Exactly.
Which highlights the limits of routine EEGs. The text notes their sensitivity is only about 29 to 55%.
Because the signal has to travel through fluid, bone, and scalp. The source area has to be large to be detected.
So video EEG telemetry, VEG, is the gold standard.
Absolutely. Admitting the patient, capturing the physical event on video while continuously recording brain waves. We use provocation techniques to trigger an event. It's the only definitive way to correlate semiology with the EEG.
Despite this, the mean latency to a PNES diagnosis is 5 to 7 years. Patients take toxic AEDs for half a decade for a functional disorder. But once confirmed, communicating the diagnosis is basically the most critical intervention, right?
It is an active therapeutic intervention. Doing it poorly invalidates the patient. Doing it correctly can immediately reduce event frequency. There are 4 required steps.
Let's role play it. Step 1, you walk in.
Step 1 is immediate validation. You reassure them the symptoms are genuine. I've reviewed the data. The episodes are very real. We know you aren't faking, and we know how terrifying it is to lose control. You neutralize the stigma straight away. Transparency. You show them the VEG data. The good news is you do not have epilepsy. Your brain cells aren't damaged, and we can safely stop these toxic medications. You give it a clear medical name, like functional neurological symptom disorder.
Step 3 is the pivot. How do you explain the functional mechanism?
Using accessible analogies. The integrative cognitive hypothesis. Your brain is a complex computer. The hardware is fine, but stress or past experiences have overloaded the software. When overwhelmed, it runs an automatic shutdown program, a reflex you can't consciously control, but we can help you reprogram.
And step 4, offering hope and treatment, which is not pharmacological, right?
Right. AEDs do nothing for core PNES symptoms. The first line, evidence-based standard of care, is cognitive behavioral therapy, CBT.
Treating full-body convulsions with talk therapy, it's remarkable.
It shows the power of functional neuroanatomy. Specialized CBT helps patients identify physiological signs of hyperarousal that trigger dissociation. It restructures cognitive responses to stress, teaching grounding techniques to interrupt the sequence. It rebuilds the cortical inhibitory control.
Let's briefly pivot back to pharmacology before the quiz. AEDs have a massive psychotropic footprint. How do we leverage that?
It's the art of neuropsychiatry. Carbamazepine and valproate are potent AEDs, but also possess significant mood-stabilizing properties used in bipolar disorder. If a patient has epilepsy and severe mood lability, valproate treats both. Lamotrigine is excellent for preventing depressive relapses. Gabapentin helps with comorbid anxiety.
But there are landmines. What's the classic drug to watch out for?
Levetiracetam. Neurologists love it for seizure control and its clean profile, but it is notorious for triggering severe, explosive aggression, intense irritability, and mood lability in some patients. If a stable epilepsy patient suddenly becomes violent or agitated after a med adjustment, levetiracetam is often the culprit.
And what about neuromodulation? Vagus nerve stimulation.
PNES involves a device pulsing the vagus nerve, projecting to the brainstem to modulate cortical networks. It's used for drug-resistant epilepsy, but fascinatingly, it significantly ameliorates depressive symptoms independent of seizure control. The electrical stimulation directly interacts with the shared networks governing both excitability and effect.
Incredible. We have covered an immense amount of ground. Let's synthesize before the quiz.
To summarize, epilepsy is excessive neuronal firing, but its psychiatric footprint spans before, during, and after the ictus. Psychiatric comorbidities are manifestations of shared neurobiological vulnerabilities. PNES outwardly resembles epilepsy, but arises from functional software crashes due to failed inhibitory networks.
They require compassionate psychiatric management, primarily CBT. Differentiating them requires precise observation of semiology, eye closure, duration, postictal state, and VEG. Beware atypical epilepsies like frontal lobe seizures, and AEDs must be chosen with deep respect for psychotropic effects.
Perfectly summarized.
All right, time to challenge your clinical reasoning. We have 6 rapid-fire clinical scenarios. We will present the case, pause for a moment, and break down the answer. If you struggle, head back to Chapter 2.4. Ready?
Let's begin. Scenario 1. A 28-year-old patient with temporal lobe epilepsy has a severe cluster of generalized seizures. Observed overnight, his confusion clears, he is oriented, exam is normal. 2 days later, entirely seizure-free, he abruptly develops grandiose religious delusions, intense paranoia, and severe agitation. Based on the temporal relationship, what is the most likely diagnosis?
Hear the thought.
The diagnosis is postictal psychosis. The critical marker is the lucid interval. He cleared completely for 48 hours before the abrupt onset of psychosis, which is pathognomonic for this phenomenon.
Scenario 2. A 45-year-old with new onset focal seizures starts a highly effective AED. 3 weeks later, seizures have stopped, but the patient with no prior psychiatric history becomes explosively angry, irritable, and physically aggressive over trivial matters. Which specific AED was most likely prescribed?
Have a think. The culprit is levetiracetam. This highlights the necessity of monitoring for cytotropic side effects. It is notorious for triggering severe aggression in vulnerable patients.
I'll read Scenario 3. You observe a patient in the EMU. At 2 a.m., they abruptly awaken from confirmed sleep. They exhibit rigid posturing, followed by chaotic, asynchronous thrashing of all limbs and pelvic thrusting. It lasts exactly 15 seconds. Eyes remain wide open. Surface EEG shows minimal changes obscured by muscle artifact, most likely diagnosis.
Think about the rules we discussed. This is a frontal lobe seizure, the classic trap. Despite bizarre movements and negative surface EEG, the short duration, onset from true sleep, and open eyes point firmly away from PNES and directly to a deep frontal electrical focus.
Scenario 4. A patient with left hemisphere focal seizures undergoes successful surgical resection. They are seizure-free, follow-up EEG is totally normal. But within a month, they develop profound treatment-resistant psychotic depression. Historically, bad seizure clusters seem to stabilize their mood. What is this alternating phenomenon called?
The answer is forced normalization, or alternating psychosis. It vividly illustrates the antagonism between seizure control and severe psychopathology, where the brain may rely on its own electrical storms to suppress a psychiatric vulnerability.
Scenario 5. During intake, a patient describes their pre-seizure aura. Overwhelming, sudden, profound ecstatic bliss, a sense of absolute truth and perfect harmony with the universe. Based on this psychic aura, what anatomical region is generating the discharge?
What did Dostoevsky experience? The discharge localizes to temporal limbic structures, anterior insula, amygdala, or temporal neocortex. Emotional auras are direct localizing signs to affective networks.
Final scenario number 6. A patient in the EMU has an episode of waxing and waning asynchronous limb movements lasting 8 minutes. You try to check pupils, but their eyes are tightly closed and actively resisting. Immediately after, they sit up without confusion. VEG confirms normal waking alpha waves. Upon communicating the diagnosis, what is the evidence-based first-line psychiatric treatment?
The diagnosis is clear. The treatment is cognitive behavioral therapy, CBT. The semiology confirms PNES. CBT is the established gold standard to restore compromised inhibitory networks.
Brilliant. We've mapped the complex territories of the storms and the shadows today, but I want to leave you with one final conceptual puzzle to mull over. We spent this entire hour drawing a very sharp line between the electrical storms of true epilepsy and the psychological shadows of PNES. Hardware failure versus software crash.
Right.
But if we accept the integrative cognitive hypothesis that PNES is an automatic execution resulting from altered functional connectivity and compromised inhibitory networks, aren't those psychological networks ultimately made of electricity too? If a software crash is just a failure of electrical communication at a higher level of abstraction, what if the boundary between neurological and psychiatric isn't a solid wall at all, but merely a different starting point on the exact same continuous circuit?
Oh, that is a brilliant question to leave them with. It challenges the very Cartesian dualism that modern psychiatry is constantly fighting to integrate. Here are the details of this episode.
Neuropsychiatric aspects of epilepsy and psychogenic nonepileptic seizures. Byline: storms and shadows when sudden disruptions in brain activity blur the boundary between neurology and psychology.